Can you describe a time when you had to adapt your anesthetic plan due to unexpected intraoperative events? What were the events, and how did you modify your approach?
During one of my shifts, I was administering anesthesia for an abdominal surgery when the patient unexpectedly developed severe hypotension despite stable vitals during induction. Initially, I ruled out common causes such as hypovolemia and anesthetic overdose, but the blood pressure continued to drop. Recognizing the urgency, I immediately communicated with the surgical team and requested a halt in the procedure while I reassessed the situation. Suspecting an undiagnosed cardiac condition or an anaphylactic reaction, I quickly adjusted my anesthetic plan. I reduced the volatile anesthetic concentration and administered fluids and vasopressors to stabilize the patient. At the same time, I evaluated airway patency and oxygenation while checking for signs of an allergic reaction. When the patient's condition improved slightly but remained unstable, I coordinated with the anesthesiologist and the surgical team to consider modifying the procedure's approach to minimize further physiological stress. Ultimately, after additional fluid resuscitation and a shift to total intravenous anesthesia, the patient's blood pressure stabilized, allowing the surgery to proceed safely. This experience reinforced the importance of vigilance, quick decision-making, and clear communication in ensuring patient safety during critical situations. It also highlighted the need to remain flexible and adapt anesthetic management based on dynamic intraoperative changes.
How do you stay current with the latest advancements in anesthetic techniques, medications, and equipment?
Staying current with the latest advancements in anesthetic techniques, medications, and equipment is essential for providing safe and effective patient care. I make it a priority to engage in continuous professional development through various avenues. Attending conferences, workshops, and seminars allows me to learn from leading experts and gain hands-on experience with new techniques and technologies. I also subscribe to reputable medical journals such as Anesthesia and Analgesia and the British Journal of Anesthesia, which provide evidence-based research and updates on emerging trends. Additionally, I actively participate in professional organizations, such as the American Society of Anesthesiologists, ASA, or the European Society of Anesthesiology and Intensive Care, ESAIC, where I access resources, attend webinars, and collaborate with peers worldwide. Engaging in case discussions with colleagues and being part of multidisciplinary teams further enhances my learning, as it exposes me to diverse perspectives and approaches in anesthetic management. Moreover, I embrace technology by utilizing online learning platforms and simulation-based training to refine my skills and stay proficient with advanced anesthetic equipment. By combining formal education with practical experience and peer collaboration, I ensure that I remain well-informed and adaptable to the evolving field of anesthesia.
Tell me about a challenging case you managed, focusing on the patient's comorbidities and how they influenced your anesthetic choices.
One of the most challenging cases I managed involved a 68-year-old patient scheduled for an emergency laparotomy due to intestinal obstruction. The complexity arose from the patient's multiple comorbidities, including severe chronic obstructive pulmonary disease, COPD, ischemic heart disease with a history of myocardial infarction, and poorly controlled diabetes mellitus. Given these underlying conditions, I knew that the anesthetic plan needed to be carefully tailored to minimize risks while ensuring hemodynamic stability and adequate oxygenation. Preoperatively, I conducted a thorough assessment, paying close attention to the patient's pulmonary status and cardiac function. I optimized his respiratory condition by administering bronchodilators and ensuring adequate oxygenation while avoiding excessive sedation, which could depress his already compromised respiratory drive. Given his cardiac history, I worked closely with the cardiology team to evaluate his functional status and optimize his fluid balance to prevent both hypovolemia and fluid overload, which could exacerbate his ischemic condition. For the anesthetic approach, I opted for a balanced technique using a combination of regional and general anesthesia. I performed an epidural catheter placement for postoperative analgesia, which allowed for reduced opioid use, minimizing the risk of respiratory depression. During induction, I used etomidate for its cardiovascular stability and carefully titrated fentanyl to blunt hemodynamic responses while avoiding excessive myocardial suppression. Maintenance involved a low-dose volatile agent combined with intravenous anesthesia to provide stable hemodynamics while ensuring adequate depth of anesthesia. Intraoperatively, the patient experienced transient hypotension, which I managed promptly with small doses of vasopressors while maintaining strict fluid control. Close intraoperative monitoring, including arterial blood gas analysis, guided my ventilatory strategy, ensuring adequate oxygenation and preventing hypercapnia, which could worsen his COPD. Postoperatively, I coordinated with the intensivist for close monitoring in the ICU, emphasizing lung protective ventilation and early mobilization to prevent respiratory complications. The patient had an uneventful recovery, and this case reinforced the importance of meticulous preoperative assessment, multidisciplinary collaboration, and a tailored anesthetic approach to optimize outcomes in high-risk patients.
How do you manage a patient with a difficult airway? Describe your preferred techniques and equipment.
Managing a patient with a difficult airway requires careful planning, preparation, and the ability to adapt quickly to evolving situations. My approach begins with a thorough preoperative airway assessment using indicators such as the Malampati score, thyromental distance, neck mobility, and history of previous intubation difficulties. If I anticipate a difficult airway, I ensure that I have a well-structured plan that includes primary and backup strategies, along with clear communication with my team. For an anticipated difficult airway, my preferred approach is awake fiber optic intubation, AFI, when feasible, as it allows for maintaining spontaneous ventilation while securing the airway. I prepare the patient with adequate topicalization using nebulized and spray-applied local anesthetics, supplemented with minimal sedation to ensure cooperation without compromising airway reflexes. Fiber optic intubation provides excellent visualization, reducing the risk of failed intubation and hypoxia. In situations where rapid sequence induction, RSI, is required but a difficult airway is suspected, I use video laryngoscopy as my first-line technique, as it offers improved glottic visualization compared to direct laryngoscopy. I ensure that adjuncts such as a bougie or stylet are readily available to assist with endotracheal tube placement if necessary. If intubation remains difficult despite initial attempts, I follow the Difficult Airway Society, DAS, algorithm, prioritizing oxygenation through techniques such as supraglottic airway, SGA, placement or high-flow nasal oxygen, HFNO, to prevent desaturation. If all non-invasive measures fail, I am prepared to perform an emergency surgical airway, such as a cricothyroidotomy, in a can't intubate, can't oxygenate, CICO, scenario. Effective airway management is not just about technical skills but also about preparation, teamwork, and knowing when to change strategies. By maintaining a structured, evidence-based approach and using advanced airway equipment appropriately, I ensure patient safety while minimizing complications associated with difficult airways.
Describe your experience with different anesthetic techniques, e.g., general, regional, MAC. When do you prefer one over another?
Throughout my career, I have gained extensive experience in various anesthetic techniques, including general anesthesia, GA, regional anesthesia, and monitored anesthesia care, MAC. My choice of technique is always guided by patient factors, surgical requirements, and overall safety considerations. General anesthesia is my preferred approach for procedures requiring complete unconsciousness, muscle relaxation, and airway control, such as major abdominal, thoracic, and neurosurgical cases. I tailor my anesthetic plan to each patient, balancing intravenous and inhalational agents to ensure hemodynamic stability while minimizing postoperative complications like nausea and delirium. I also incorporate multimodal analgesia to reduce opioid requirements and enhance recovery. Regional anesthesia plays a crucial role in my practice, particularly for orthopedic, obstetric, and certain general surgical procedures. I commonly perform spinal and epidural anesthesia for lower limb and abdominal surgeries, as they provide excellent analgesia while reducing the risks associated with GA, such as respiratory depression and hemodynamic instability. For upper limb surgeries, I often use brachial plexus blocks, which allow for prolonged postoperative pain relief and faster recovery. Additionally, I integrate regional techniques like TAP blocks and paravertebral blocks to enhance pain control in multimodal analgesic plans. Monitored anesthesia care, MAC, is my preferred technique for minor procedures or cases where patient cooperation is required, such as endoscopic, interventional radiology, and certain ophthalmologic surgeries. I carefully titrate sedation using agents like dexmedetomidine or propofol while ensuring airway patency and hemodynamic stability. My goal is to provide patient comfort while maintaining spontaneous breathing and avoiding deeper levels of sedation that could compromise safety. My experience with these different techniques has reinforced the importance of individualized anesthetic planning. By carefully assessing patient comorbidities, surgical needs, and recovery goals, I select the most appropriate approach to optimize outcomes and enhance patient safety.
How do you handle a situation where a patient is anxious or uncooperative before a procedure?
When faced with an anxious or uncooperative patient before a procedure, my approach is centered on empathy, clear communication, and individualized reassurance. I begin by acknowledging their concerns and creating a calm, supportive environment where they feel heard and understood. Many patients fear anesthesia due to misconceptions or past negative experiences, so I take the time to explain the procedure in simple, non-technical language, addressing their specific worries while reinforcing the safety measures in place. Building rapport is key to alleviating anxiety. I use active listening and open-ended questions to understand their fears, whether it's a fear of pain, loss of control, or waking up during surgery. If a patient is particularly anxious, I offer relaxation techniques such as guided breathing or distraction methods like light conversation. For pediatric or cognitively impaired patients, I adapt my approach by engaging caregivers, using reassuring tones, and sometimes incorporating visual aids or playful interactions to build trust. Pharmacologic management is also an option when necessary. If non-pharmacological methods are insufficient, I may administer a mild anxiolytic, such as midazolam, in an appropriate dose to ease preoperative distress while ensuring the patient remains cooperative and safe. However, I always prioritize non-medication strategies first, as they help establish trust and improve the overall patient experience. In cases where a patient remains uncooperative due to extreme anxiety, underlying psychiatric conditions, or developmental disorders, I collaborate closely with the surgical team and, if needed, involve family members or a psychologist to ensure a patient-centered approach. My goal is to create a sense of security and confidence, ultimately helping the patient feel more at ease before their procedure.
How do you ensure accurate medication administration and prevent medication errors in the operating room?
Ensuring accurate medication administration and preventing medication errors in the operating room is a fundamental responsibility that I take very seriously. My approach is based on strict adherence to standardized protocols, vigilant verification processes, and effective communication with the surgical team. Before administering any medication, I follow the 5 rights principle: the right patient, right drug, right dose, right route, and right time. I personally verify each medication label, concentration, and expiration date before drawing it up, ensuring that there is no room for misinterpretation. I also use color-coded syringes and clearly labeled drug trays to minimize the risk of syringe swaps, a well-known source of errors in anesthesia practice. In high-risk situations, such as using neuromuscular blockers or vasoactive drugs, I double-check my calculations and, when necessary, confirm with a colleague before administration. I also adhere to weight-based dosing, particularly in pediatric and critically ill patients, to prevent overdosing or underdosing. Utilizing technology further enhances safety. I make use of barcode scanning and electronic medical record (EMR) systems when available, which add an extra layer of verification. In addition, I always maintain clear documentation of all administered medications in real time to ensure transparency and accuracy. Another critical factor is communication. I practice closed-loop communication when responding to verbal medication orders and actively engage with the surgical and nursing teams to ensure alignment on medication plans, especially for infusions, antibiotics, and emergency drugs. Finally, I regularly participate in medication safety training and stay updated on best practices through continuing education and case reviews. By combining vigilance, adherence to protocols, and a culture of safety, I ensure that medication errors are minimized, ultimately prioritizing patient safety in every anesthetic case.
Tell me about your experience working in a team environment. How do you communicate effectively with surgeons, nurses, and other members of the surgical team?
Working in a team environment is an integral part of anesthesia practice, and I have extensive experience collaborating with surgeons, nurses, and other members of the surgical team to ensure safe and efficient patient care. Effective communication is the foundation of this teamwork, and I prioritize clarity, professionalism, and adaptability in every interaction. At the start of each case, I participate in preoperative briefings where we discuss the surgical plan, patient-specific concerns, and potential complications. This structured approach ensures that everyone is aligned and prepared for any contingencies. During the procedure, I maintain open and proactive communication with the surgeon, providing real-time updates on the patient's hemodynamic status and any anesthetic adjustments. If unexpected challenges arise, I convey critical information concisely and use closed-loop communication to confirm shared understanding and coordinated action. Collaboration with nurses is equally essential. I work closely with them to ensure that medications, fluids, and equipment are readily available and that perioperative protocols are followed. I also value their input, as they often provide crucial insights about the patient's history and intraoperative needs. In high-pressure situations, such as emergencies or sudden changes in a patient's condition, I remain calm and decisive, clearly delegating tasks while actively listening to team members. My ability to foster mutual respect and maintain a solution-focused approach has been instrumental in managing complex cases effectively. Beyond the operating room, I engage in interdisciplinary discussions, case debriefings, and quality improvement initiatives to enhance teamwork and patient outcomes. By maintaining a culture of collaboration, respect, and clear communication, I contribute to a cohesive surgical team that prioritizes patient safety and optimal care.
Describe a time you made a mistake in your practice. What did you learn from it, and how did you change your approach afterward?
Early in my career, I encountered a situation that reinforced the importance of vigilance and double-checking even routine tasks. I was preparing to administer an intravenous medication during a case and, while I had correctly selected the drug, I almost administered it before realizing that I had drawn up the wrong concentration. Fortunately, I caught the error in time through my standard verification process, and the patient was not harmed. However, this moment was a significant learning experience for me. After reflecting on the situation, I realized that fatigue and a fast-paced environment had contributed to my near miss. I took proactive steps to prevent similar mistakes in the future by adopting a stricter self-checking routine, including an additional pause before administration to verify the drug, dose, and syringe label. I also made it a habit to verbalize medications when preparing them, reinforcing my focus and ensuring accuracy. Additionally, I began advocating for the use of pre-filled, standardized syringes for high-risk medications whenever possible, reducing the likelihood of human error. I also actively participated in discussions on medication safety within my department, sharing my experience to emphasize the importance of vigilance and system-based improvements. This experience reinforced my belief that errors, while unfortunate, are powerful opportunities for growth. It strengthened my commitment to patient safety, attention to detail, and continuous improvement in my anesthetic practice.
What are your career goals as a nurse anesthetist? Where do you see yourself in 5 years?
As a nurse anesthetist, my primary career goal is to continually enhance my clinical expertise while contributing to patient safety, anesthesia education, and healthcare advancements. Over the next 5 years, I see myself growing in both clinical practice and leadership, taking on more complex cases, refining my skills in regional anesthesia, and staying at the forefront of emerging anesthetic techniques and technologies. In addition to clinical growth, I aspire to be actively involved in mentorship and education, guiding aspiring anesthesia providers through training programs or workshops. Sharing knowledge and fostering the next generation of anesthesia professionals is something I am passionate about, and I hope to contribute to continuing education initiatives within my institution or professional organizations. I am also interested in research and quality improvement projects that enhance patient outcomes and anesthesia safety. Whether through participation in clinical trials, implementation of evidence-based practices, or involvement in policy development, I aim to contribute meaningfully to advancements in perioperative care. In the long term, I see myself in a leadership role, such as a senior anesthesia provider, clinical coordinator, or faculty member in an academic setting. Regardless of the specific path, my ultimate goal is to continually refine my practice, advocate for patient-centered anesthesia care, and make a lasting impact in the field of anesthesia.